My colleague, I will explain something until our other colleague join us. Today I will run six hot Viva seat about liver focal lesion. But before we starting, I wanted to declare that LI-RAD almost is out of the scope of FRCR. But however, I will give you some tricks and some important notes about how to be sure this is at least a malignant hepatic lesion or a benign HCC or other lesions. This is the target of today. In my opinion, after all of you cleared FRCR, LI-RAD is the most important radiological classification because it is highly able to differentiate HCC from malignant from benign. If you applied most of the criteria of LI-RAD in any hepatic focal lesion in high-risk patient, I think your diagnosis will be more than 90% accurate. But take care, LI-RAD classification uh, only apply to high-risk patient. What is the high-risk patient? Hepatic patient. Number one, hepatic cirrhosis, but not congenital hepatic cirrhosis or not vascular hepatic cirrhosis like Budd-Chiari syndrome. Number two, hepatitis C, B patient, hepatitis B. Could anyone know why especially hepatitis B? Why hepatitis B is very high risk and any patient who is hepatitis B should be applied to LI-RAD criteria? Anyone know? I see to answer.
Sir,
Yes,
sir, the patient can progress to HCC without forming hepatic cirrhosis. It
excellent,
can directly form HCC. Yes,
excellent.
sir.
Why? Why?
Sir,
Why?
I don't know the answer, but the
Because
patient directly forms. Yes, sir.
you are right. Number one, because the patient may directly develop HCC without cirrhosis. Number two, and this is why, because hepatitis B virus is highly carcinogenic. Okay. Uh, Number three of the risk factor, any patient who developed previous HCC. If you have any of these three criteria, now you are presented with an examination, especially CT or MRI for this high-risk patient, you should apply the major feature and the ancillary feature of LI-RAD. This is just a general introduction. I will not talk about them today, but I will give you some keys to be sure this is malignant or not, or this is HCC or not. And I think this is important in our RCR exam. So let's start with our first candidate. Are you ready?
Good evening, sir. Yes, sir, I'm ready.
Good evening. See, doctor, this is static images, I think, all of them. See, doctor, this is 65-year-old male patient with liver cirrhosis and portal hypertension, and he underwent an MRI. This is his MRI. You can start.
Okay, these are the spot images of axial sections MRI of a 65 years old man. The left one is T2 fat set imaging,
Okay,
and the right one is T1
excellent.
T1 weighted imaging in portal venous phase. T1 plain imaging.
T1,
So this is T1, this is T2.
see. T1, we don't know is this focal lesion or IVC, but at least do you detect any other contrast here? Here in this vessels?
No.
Number two, do you expect
No.
Post contrast is done through non-fat set.
No.
So this is only T1. Yeah, go on. What happened here?
Okay. There is a coarse liver ecotexture. I can appreciate that the liver has cirrhotic margin,
Excellent.
and there is along the right portal vein at its distal part. There is the iso-intense lesion, rounded lesion to the background parenchyma, and this lesion has become hypointense on the T2 weighted images.
Okay.
Another lesion which is seen along the left portal vein, it
One
is
second. One second.
hypointense on T1 and it is
What is it? What is around the,
hyperintense on T2 weighted imaging.
what is,
There is
doctor?
there is a retraction and there is architectural distortion.
See, doctor, what is the surrounded hypointense signal here? What do you think?
Uh, this is it is causing aborting and displacement of the vessels.
Okay, let's see. This is post contrast. Okay, what happened? If I am telling you this is post contrast and this is post contrast, which phase here?
Sir, the left one is early arterial and the right one is late arterial phase. And because I can see the aortic contrast in aorta,
yes.
or it might be another lesion,
This is
but the
arterial.
background parent.
This is arterial, okay, and this is delay
Okay.
according to Radiopedia. What happened here? Tell me, please. What happened?
The lesion is taking up contrast, and there is
What is the
there
degree
is
of contrast uptake? This is one of the most important criteria in the liver. We should tell. What type of contrast uptake here?
sir, it is homogeneous contrast enhancement.
Yes, homogeneous. But in comparison to the liver parenchyma, is this hyper enhancement, iso enhancement?
Sir, it is a little bit increased than the background parenchyma.
So it is hyper enhanced.
Hyper enhancing.
Okay, what happened here?
In the delayed phase, the central part of the lesion, which was taking contrast, has washed out, but there is a
Excellent.
subtle peripheral enhancement.
Okay, one by one. What? Give me differential diagnosis.
So, sir, in the delayed phase, the central part is not enhancing. So it can be either HCC
Yes,
or it can be cholangiocarcinoma
no.
or
This lesion,
no.
by the way, has typical criteria. Typical criteria. It is HCC. Okay? Why?
Okay.
Why it is typical HCC? It has the three typical major criteria.
One of it is arterial enhancement and
Which
venous
type?
washout.
One second. Which type of enhancement? Not all enhancement is typical for HCC. Only one type. I mentioned before.
Homogeneous arterial.
Homogeneous? No. Hyper enhancement. Okay? So, my
Hyperenhancement.
colleague,
Okay.
don't worry, doctor. This is just to add to your knowledge, this lecture of today. This is HCC. Why? Number one, in the arterial phase, it is hyper enhancing in comparison to the liver parenchyma. And this is the most important sign of HCC. Number two, in delayed or on portovenous, we must see washout. What is the definition of washout, our doctor?
That the lesion become hypoenhancing than the background lung parenchyma.
Excellent.
Background liver parenchyma.
Yes, excellent. The lesion must be less enhanced in comparison to surrounding parenchyma. Number three, what is this peripheral delayed enhancement? Peripheral delayed. What is this? This one.
Uh,
This one.
this is the capsular
Excellent.
enhancement.
Excellent. So we have the three main criteria of HCC. Can you repeat to our colleague, please? Number one, arterial phase hyper
Enhancement.
enhancement. And this
Num-
hyper enhancement should be non-peripheral, should be central. Number two, wash out. Wash out means not only loss of contrast, no, it loss of contrast to be less than the surrounding parenchyma. Number three, surrounding capsule. These three criteria is the three typical criteria of HCC. I will not talk about the LI-RAD classification, 3, 4, 5. This is not our business today, but at least you should keep in mind how to be sure about the major criteria of HCC. Why? Because I take some feedback from our colleague of last exam, and any case now is expected to be presented in our Viva. So I'm trying to cover everything. At least when the examiner again and again ask you about what is the major criteria of HCC, number one, AFI. AFI means arterial phase hyper enhancement. Number two, washout. Number three, in a capsule, peripheral capsule. This hyper enhancement should be central, not peripheral. Doctor, why is this not cholangiocarcinoma? Give me two or three causes.
Sir, one of the reason is that cholangiocarcinoma has increased enhancement on the delayed phase.
Excellent.
Secondly, it has a capsular retraction. And thirdly, there is background of at least some of the ductal dilatation should be there, which is not present in this case.
More than excellent. Thank you, doctor, so much. It was a case of HCC. Okay. What is
Thank you,
it?
sir. Thank
The
you.
patient has history of TIPS, and this is the tip of TIPS. What is this? Radiopedia mentioned this is maybe lesion, something like this, but I have a doubt because we have a static image. So I talk only about what I'm sure about. This one was HCC. What is your next step, my doctor?
So next step is to correlate with alpha fetoprotein level and to see the entire stack if it is invading any vein to rule out the criteria for TACE and refer it for TACE, and to see multiplicity and synchronicity of the lesions, portal vein invasion, and to see if any lesion in portal vein, it's arterial enhancement.
Okay. Um, what is your next step? Do you want to do biopsy or not?
Um, no, I think biopsy is not needed. AFP, alpha fetoprotein correlation, and
If
refer to MDT for TACE.
okay, by the way, MRI, triphasic MRI and triphasic CT is highly diagnostic of HCC. But however, if your clinician insists to do biopsy, which technique will you use? Anterior procedure or lateral procedure? Tell me.
Sir, preferably lateral,
Okay,
because
lateral. Why? Why?
uh, we want to minimally damage the vessels, and if
Yes, we
we
have
come along
vessels.
the lateral plane.
Okay. Okay. Somebody somebody asked one question. What do you mean by capsule? Capsule means fibrous capsule. If you look here, there are peripheral non-arterial enhancement. And then in the delayed, it take delayed enhancement. So this is a fibrous capsule. Why? Why this is fibrous? Because it take in delayed. And HCC is the most common tumor in liver that have capsule. Okay, my colleague? Sometimes we have something called targetoid enhancement. And this is very common with metastasis. How to differentiate both of them? Targetoid metastasis should show arterial, peripheral arterial enhancement. because it contain cell and vascular يعني stroma. Not like this fibrous capsule. Look here, my colleague who asked the question. This fibrous capsule not enhanced here and only show enhancement in the delayed. It was a case of HCC. By the way, anyone wanted to do the LI-RAD, we will measure the maximum size. To be sure, anyway, LI-RAD or to diagnose HCC, you need the three criteria plus more than 1 cm, 1 centimeter. More than 1 centimeter will put you on the table of LI-RAD. But if you are above 2 centimeter, it is highly suggestive of HCC. There are two different pathways. If you have one cm or you have from 1 to 2 or above 2 cm. Okay, my colleague, I think this lesion will take at least LI-RAD 5. It is sure or highly suggestive of HCC, and I will give it LI-RAD 5. Thank you, my doctor. Next candidate.
Thank you, sir.
Next one.
Assalamu alaikum.
Alaikum salam, doctor. Doctor,
Sorry, my mother,
no problem. I
I
will.
cannot.
This
Thank you.
patient presented with esophageal bleeding. By the way, my colleague, my advice to you, even in practice, when you are dealing with a hepatic CT or MR, you should at least use two windows and compare arterial with non-enhanced or anything because you must compare. It is very difficult to take a decision in only one phase. My colleague, this patient has, this is one, this is another one. This patient has esophageal varices. Look here. Yeah, start.
Yes, I have been presented with axial images CT scan for a patient with esophageal varices taken in the arterial phase and venous phase. First of all, I can see that there is a moderate amount of prehepatic free fluid also surrounding the spleen in the presplenic area.
Yes.
I can see that there is cystic dilatation seen within the right liver lobe mainly, and I can see that the gallbladder appears distended without any stones, and I can see that there is varices
Doctor,
seen surrounding the
can I stop?
gallbladder.
Can I stop you? Thank you for
Yeah.
this descriptive information. But do you think if you are examiner and there are these big disasters, you are giving this case to the candidate to talk about the side or less important, or you want the candidate to start with the core, with the main problem?
Yeah, with the main problem, of course. Yeah.
That is why some of us go the same exam and to the same examiner, and one get a good mark and one didn't pass. Okay, take care, my
Yes.
colleagues.
Yes.
The examiner is a human being, and they are for يعني some of them for 4 hours or 6 hours are examining a candidate. So try to be concise and to the point. Start again, doctor. What about the
Yes. I,
Hmm?
what is the question, sir?
Start from the liver, please.
Yes, I can see that there is diffuse cystic dilatation seen involving the right liver lobe. I can see that in the arterial phase, there is enhancement of the blood vessels, mostly branches of the portal vein, and I can see that there is areas of hyper enhancement lesion, one seen in the inferior aspect of the liver. These could represent intrahepatic biliary ducts dilatation.
Doctor, are you sure?
Yeah.
Are you sure? If this intrahepatic biliary duct dilatation It should be angiocarcinoma. Could you expect
Yes.
angiocarcinoma to cause convexity or retraction?
No, it causes retraction.
Okay.
Here I can see that the liver surface appears irregular and nodular.
So this is the starting point. You should start
Yeah,
telling the examiner this is a cirrhotic liver and showing,
cirrhotic liver.
showing we start to describe this one. What is this one? What do
Yes.
you think?
I think maybe this is a lesion
Yes,
which contain multiple cystic areas,
necrotic
and I
areas.
can see that there is another
Necrotic,
lesion. Yes,
necrotic areas. Okay. What else? What else? What is
Uh,
this phase, doctor?
arterial phase.
Okay. I told you, يعني usually work with comparison. What do you think generally? What happened? This is, if I told you this is venous, portovenous. This,
Mhm.
if this the same slice as this, what happened from here to here? What do you think? What happened from here to here? Hmm.
There is increase in the size of the necrotic space within the mass lesion, and
See, see, see. By another term, there are some heterogeneous contrast here, correct?
yes,
Could you detect the contrast here or
no,
hypodensity?
no,
What is the name
no,
of
it is
this phenomena?
hypodensity.
What is the name of this
This
phenomenon?
is washout.
Excellent. So the lesion here enhanced, show some foci of hyper enhancement. And
Mhm.
then what happened here? Wash out, okay?
Washout.
What
Yes,
else?
yes.
Please have a look at the portal vein. What happened to the portal vein? See?
I think in the venous phase, I can see that there is filling defect seen within the filling defect seen within the superior mesenteric vein that extending into the portal vein.
Okay, what your differential diagnosis about this filling defect in tumoral case?
This filling defect, it could represent tumoral thrombus from
Excellent.
the malignancy, that cirrhotic
Or
liver and HCC.
or
It could be, or it could be due to I don't know actually
blend
other
thrombus.
causes.
Okay, blend thrombus. Thrombus يعني
Yes,
non-tumoral thrombus. How could you
yes,
differentiate between tumoral thrombus and blend thrombus? Blend, B-L-E-N-D, B-pole. B-pole, okay?
yes.
Blend. How
Okay.
could you differentiate or be sure this is tumoral thrombus or blend thrombus?
I don't know the exact answer, but I will go with enhancement. If this showed enhancement, the
This is the
thrombus, it
slice.
could be tumoral thrombus.
This is the slice of portal of in the portovenous phase. This is the same slice in arterial phase. What do you think?
Yes.
Tumoral or blend? Tumoral or non-tumoral?
I think it is tumoral
Why?
because I can see there is enhancement in the
Excellent.
arterial phase, which is should
Ex-
watch out within the venous phase.
Okay, very nice. Give me conclusion. Give me conclusion, please.
Yes. The conclusion, I have been presented with cirrhotic liver that
Yes.
showed a huge mass lesion.
Uh-huh.
And also, I can see that there is areas of hyper enhancing lesion within the arterial phase, which could represent regenerative nodules. The liver size is enlarged. Appearances are those of hepatocellular carcinomas with
Is
secondary portal vein thrombosis.
excellent. By the way, we are only talking about this one. We didn't talk about the other because the other is malignant. Okay, and I will show. Okay, thank you, doctor, so much. My colleague,
Thank you.
try to start from the core. Okay, the examiner, I said many times before, the examiner give you one case for its dedicated pathology in his head, okay, in his mind, and want from you to start with. Okay, what happened here? See, my colleagues, this is cirrhotic liver. Shows multiple heterogeneous and heterogeneously enhanced lesions infiltrated the right lobe. One, two, okay, three. There are one in the segment 6 here. See, doctor, this is not a regenerated nodule. Why? It shows arterial hyper enhancement. This is the most classic. This one especially. HCC. Why? The all criteria of HCC you can find here. Why? Why? I will show you. See? AFI,
What else?
non-peripheral, non-REM or non-peripheral AFI. What mean? Central hyper enhancement and washout. This is very classic. But this is not the most important. The most important, this another one. The most important one, this one. Okay, what happened? This large infiltrative HCC, look, infiltrate the main and the main branches of portal vein. Very important. This lesion can be classified as L-RAD tumor in vein. By the way, this is the worst classification. Why? Because this patient is end stage. Why? It is not eligible for liver transplantation. Very bad situation. So it is very important. Second tip of today session, please in all HCC check portal vein, especially portal vein or hepatic veins. Invasion. Why? Because it is highly miserable to the patient. Okay, my colleague, if you look carefully, you will see some here, especially in arterial. See, there are some THAD, transient hepatic enhancement difference, due to portal vein invasion. Okay, the right lobe here, generally all the right lobe compensatory hyper enhanced by the hepatic artery. Okay, due to occlusion of the portal vein, and this is very important sign of portal vein occlusion. If you, when you are scrolling like this, compare both lobe with each other. There are, look here there are hyper enhancement in comparison to the medial segment of the left lobe. So it was a case of HCC invading the portal vein. Thank you, doctor, so much. Next
Thank you.
candidate. Next candidate.
Yes, sir. Yes, sir.
Okay. Doctor, last doctor, do you think last case there are any potential, يعني, there are any possibility of rupture of one of the HCC or not? Our
Yes, in the last case, if there is any possibility of what?
yeah, of rupture of any of this HCC, could you detect any
Yes, could be. Yes,
in
there
the
is a
last?
chance. Yeah.
Okay, there are a chance, but did you detect any sign of rupture?
No,
Okay, what is the
no.
signs of rupture? What is the signs of?
Generally speaking,
Yes.
I don't remember the signs of
What about the ascites?
rupture.
What's your opinion about the ascites? Is this hyperdense ascites or the normal watery ascites?
I want to check it again.
Hmm?
It's look like watery. There is no
Watery,
hyperdensity within.
similar to gallbladder. So this is not hyperdense. Number two, in the arterial phase, no any contrast leakage here. Okay?
Yes.
At least two signs of non-hemorrhagic ascites. Thank you, doctor. My colleague, I'm
Thank you.
trying to cover as much as possible of all question. Okay, next candidate.
Yes, sir.
Welcome, doctor. This is 65-year-old male patient with elevated alpha fetoprotein and suspected HCC.
Okay. Sir, I have been provided with multiphasic CT liver dynamic. There is a
Okay.
non-contrast phase and early arterial phase on the left side. So
Excellent.
on the non-contrast, I can see that the liver has slightly undulating margins, but it is not clear-cut cirrhotic. The margins are slightly undulating. On non-contrast, there is a large heterogeneous appearing lesion which is occupying the left lobe and also extending partly into segment 4. It shows heterogeneous appearing arterial phase enhancement um, and arterial phase enhancement. And now
Mainly,
I want to
mainly peripheral or central?
it is heterogeneous appearing. It is also inside the inside the in the center of this lesion, and also at the peripheral. So this is likely a heterogeneous appearing
Excellent.
non-REM hyperenhancement. Yes. So I
Okay.
want to look at the portal venous phase to look for the washout of this lesion. On the portal venous phase, I can see that there is central washout in this lesion, and there is a hyper-enhancing rim surrounding this lesion. Given the criteria of non-rim arterial phase hyper-enhancement and central washout, this is highly concerning for HCC. I want to look at the portal vein and the hepatic veins to check for the extension of the this lesion into the hepatic veins. The left hepatic vein is displaced by this mass.
Excellent.
The left portal vein is compressed by this lesion. However, it appears patent without any definite tumor thrombus. The right hepatic vein appears normal. The left hepatic vein
Doctor,
appears to be in the center.
but if I told you this is a delayed and there are enhancement, peripheral enhancement, do you think it has any possibility to be hemangioma?
Uh, So in the hemangioma, there is arterial phase discontinuous peripheral
Brilliant.
enhancement, and on
Brilliant.
the delayed, it becomes iso-intense, and there is centripetal filling of this lesion. There is washout in the center, so this is not hemangioma. This is
Excellent.
highly concerning for HCC, and the peripheral hyperenhancement is concerning for a fibrous capsule of this lesion.
Okay.
Um,
What's your final diagnosis?
I am thinking of HCC, given the enhancement pattern, and also the history of AFP levels are raised. So also the portal vein is not involved by this lesion. Only the left hepatic vein is centrally
What is
involved
your
in this
next step?
mass.
What is your
So I
next
would
step?
I would refer the patient to the hepatobiliary MDT for further management. This patient can undergo TACE or any other treatment because the portal vein is not involved.
What is
I
this?
would also
What is this?
TACE is the uh, trans arterial hepatic chemoembolization. We use
Excellent.
the arterial pathway and we embolize the hepatic artery. So the arterial supply, the supply of this lesion is mainly from the hepatic artery. So if we embolize the hepatic artery, this can undergo ischemia, and this can undergo reduction in the size of this lesion.
Thank you, doctor, so much. Really brilliant. Our doctor here يعني mention us two major criteria of the HCC. What happens? This is non-cirrhotic liver. Okay? But look here, there are central heterogeneous hyper enhancement. And when I give him the portovenous, he remarks that the center is there are some washout. Look, at least here, hyper enhancement. Look, centrally. Here, not present. And besides that, the center here is less bright or less enhanced than the parenchyma, so this wish out. Okay. And when I ask him, doctor, this is in the delay, there are peripheral enhancement. Why this is not hemangioma? Especially there are peripheral arterial. He told me the hemangioma must have peripheral discontinuous. This is continuous, my colleague. Okay. And I will add something to him. Number two of the hemangioma must follow the blood pool. This peripheral enhancement should be the same as here. Number one, it should be discontinuous. Number two, should follow the blood pool. Okay? Should follow the blood pool. Here may follow here, but in the delayed, sorry, this is portovenous. Here, this is portovenous. The periphery is more enhanced than the blood pool, the venous blood pool, or here, because this is portovenous. So this is not hemangioma. And in the delayed, you should see closing iris sign. So number one, we exclude the most relevant benign lesion, which is hemangioma. And this is our task in the exam, to rule out any mimic, any benign lesion. Because if you told the examiner at least this is malignant looking and this is necrotic center, doctor, it may be HCC versus any other malignant lesion, the examiner will be happy. But if you confuse, doctor, it may be hemangioma, doctor, because the examiner sure will not pass you. Why? Because there are very definite criteria for malignancy, especially HCC, and hemangioma. Okay, my colleague, this fortes maybe the examiner, if he asks you, is this for biopsy? Don't refuse. Why? Because the patient here is not cirrhotic and we didn't have any history of HBV. He is not non-cirrhotic or hepatitis B. So, in my opinion, next step must be biopsy to diagnose, because the lesion has large necrotic center and it is characterized of other malignancy. Anyway, thank you, doctor, so much. It was a case of malignant liver lesion, most likely HCC, because of the central hyperenhancement and washout. Thank you, doctor, so much. By the way,
Thank you, sir.
I'm not sure is this peripheral capsule or not. Why? Because the fibrous capsule should not show arterial peripheral enhancement. Okay, doctor? The classic. I'm talking about the classic fibrous capsule. Thank you, doctor, so much. Next candidate.
Assalamu alaikum, sir.
Salam. Doctor, this patient has jaundice and he is known to have virus C. Okay, go
Okay.
on.
So this is the axial section of triphasic CT liver. I can see that on the plane image, there is a hypodense area noted, which is involving the segment 8 and um, and and extending to segment 6. I'm provided with the arterial phase, and in the arterial phase, I can see that it is showing heterogeneous enhancement. I'm looking to see for its extension on the arterial phase. And I can see that in the arterial, and comparing the arterial with the portovenous phase, I can appreciate that there is some area of washout that I can appreciate. I'm now trying to look at the portal vein, and I can appreciate that the
Where
portal
is the area of
vein
washout?
appears.
One second, one second. Where is the area of washout? Where?
Um,
Where? I,
uh,
this is the
yeah,
arterial, this is the portal. Okay? Where is
yes.
one by one? I will take one by one, slice by slice. Okay.
Okay. Yes, this area appears to be of washout to me
Why?
because the capsule,
Why this
the
area of
cap,
washout? Why?
because I can see that the capsule is increasing enhancement, and the central area, I can see that the area of the arterial blush that I see on the on the arterial face
See,
is now, yes,
this
yes, yes,
the
yes,
area
this
of
area.
washout, because it looks like
Yes,
less than the parenchyma. What is?
yes.
There are very important sign here. What happened? What happened? This is portal venous phase.
Yeah, the branch, the right portal vein is thrombosed, the extension of tumor thrombus. Yes.
Okay, is this tumoral thrombus or blend thrombus? How could you differentiate?
Yeah, so I will look at the arterial phase again to come. Yes, I can see that there is a washout in this tumor thrombus as well. Yes, so it is a tumor thrombus.
There are heterogeneous arterial enhancement with venous washout.
Yes.
The most important is the arterial enhancement, doctor. There are why? Because this is tumor. Okay,
Yes.
tumor cell. Okay, so what's your final diagnosis? Only the
So
doctor, the extension only to the portal vein. Look here.
no,
What happened here?
yes, IVC. Yes, IVC is also involved. So I will look at the hepatic veins also, and I can see that the I can
Yes. What other structure you should exclude? You should tell the examiner, doctor, urgently, I wanted to examine another structure. I will help you. The tumor extend.
yeah, the right atrium. Yes.
Excellent. Because it looks like extend upward. All of this
Yeah.
tumor. Look the enhancement. Look here in the arterial. Okay,
Yes.
so give me a final diagnosis.
Yeah, so it's basically angioinvasive hepatocellular carcinoma
Yes.
in aggressive, and I will urgently inform and arrange for the serum alpha fetoproteins if the liver margins appear irregular to me, and if the patient is already not a known case, then I will go for the viral markers also, and I will yeah, discuss in the hepatobiliary MDT for further management.
How could you answer your clinician if he asks you, is this patient eligible for urgent transplantation or he should
No.
take his, take his
No, because the tumor thrombus has extended into the IVC also, and the extending to the right atrium. So that is why it's not able to be transected.
not eligible for transplantation.
Yeah.
Thank you, doctor, so much. This is another case. See, I didn't speak about LI-RAD itself, but about the dangerous sign. Why? If a case like this presented to you in the Viva and you didn't talk about how dangerous or how critical the invasion of this mass to the vessel, be sure that the examiner will be unhappy. If you wanted to add more information, doctor, it may be LI-RAD tumor in vein, he will be so happy. Okay. By the way, the classification here, LI-RAD TIV, tumor in vein. And this is the worst classification in LI-RAD. By the way, my colleague start with the liver is cirrhotic or not, at least radiologically. Most of you didn't mention it. This is very important. Why? Because LI-RAD is applied to cirrhotic patient. Okay, my colleagues?
Okay, sir. Okay, so thank
Okay.
you. So can I ask a question?
Okay, but please, easy question.
No, sir. Just I want to ask is that you were just talking about the liver biopsy approach. That I just want to ask again what you were saying about the approach.
See, we are trying to use either anterior approach or lateral approach according to how to avoid the vessels. One example here, this patient, see, if you try with anterior approach from this slide, you will injure this hepatic vein. Okay?
Okay.
Whatever, what is this? Yani anyway, you will injure this vessel. Okay? But
Okay.
but from here, we are trying from lateral to avoid any vessel. But two criteria should be within the biopsy. Number one, you shouldn't take biopsy from this necrotic center. It will has no value. Number two, you must go through some normal parenchyma. Why? Because this parenchyma act as cushion or hemostatic. Number three, the patient should not have this ascites. Okay, so any ascites is number one contraindicated, absolute contraindication. except for urgent cases. But we are talking about the classic biopsy. Should not be done with biopsy. Why? Because if you did a biopsy and there are ascites, this ascites will cause hemorrhage. Why? Because the liver is not compressed against the chest wall or the abdominal wall. It is prevent the effect, hemostatic effect of the abdominal wall or the chest wall. So ascites should be removed first of all. Number two, take from the tumor proper. You open by sonar guided, you open the Doppler box to avoid any vessel, and you should have a biopsy from the tissue, the malignant tissue, but you should go through some of the normal liver parenchyma. Is it clear for you, doctor?
Okay, thank you so much. Thank you. Yes.
By the way, my colleague, this is the basics of biopsy. Keep in your mind, write in your notes. Now, really, we don't know this FR people, what will they ask? So I'm trying to give you as much as possible information, relevant information. Next candidate. Hello? Hello? Dr. Ahmed?
अस्सलाम वालेकुम सर
Please.
Salam. Doctor, this
जी
patient,
अस्सलाम वालेकुम सर
Salam, 80,
अस्सलाम वालेकुम
yes, alaikum salam. This
हेलो
patient, yes, can you hear me?
यस यस
80-year-old male patient with right hypochondrial pain, non-hepatitis B patient. What happened here? Go on. Hello? Hello? Doctor, we can't listen you well.
दिस इज सीटी एब्डोमेन नॉन कंट्रास्ट एंड हेलो
Yes?
सर आई विल चेंज द नेट सर यू कैन हियर मी
Yes,
दिस
doctor, go on.
just and arterial face images are non-contrast images. I can see a large, well-defined lobulated hypodense lesion in the segment 7 of the liver, which shows internal areas of necrosis. On arterial phase, it shows heterogeneous post-contrast enhancement.
Okay.
Spleen is enlarged.
Doctor,
Liver,
what
liver.
is the name? What is the name of this appearance here or this sign? See? What is the name either of the type of contrast uptake or the sign?
Sir, infiltrative type of lesion.
I'm not talking about the
Heterogeneous
legal nature. I'm talking about
enhancement.
the contrast appearance. It is very characteristic appearance. See, this is a big lesion, correct? Hello? Hello?
Okay.
This is
Yes, sir. Yes, sir.
a big lesion. And
Yes, sir.
you see inside this lesion another nodules. What is the name of this sign or this appearance? Nodules of different nature. Some of them are hyper enhanced, some of them are necrotic. So, what is the name of this sign or this pattern of contrast uptake? Hello? Hello? Doctor, can you listen
Sir,
me?
exactly, I don't know the name.
Okay, this is
Exactly, I don't know the name.
yeah. This is mosaic type of contrast uptake. What is mosaic?
Hello?
Yes, I listen, I hear you. This is
Yes, sir. Yes, sir.
this is mosaic type of contrast uptake or nodule within nodules. Okay, this is a big lesion contain different nodules of different pathologies, and this is very characteristic for some hepatic
Okay, sir.
lesion. Okay, uh, you can continue your description. This is the arterial. What happened at least? See, for
Okay.
these nodules. Look here. This is the nodule. here.
Okay,
Hmm.
some shows marked enhancement, some shows heterogeneous enhancement. Yes.
Yes. Could you detect
Some
any?
lesions shows marked
Yeah. Could you detect any washout?
enhancement and some shows heterogeneous post contrast
Okay. Could you
enhancement, while some of the lesions are non-enhanced.
Okay, could you detect any washout? This is the hyper arterial enhancement, and here at least, could you detect any washout?
Sir, I want to see the portovenous phase and delayed phase to confirm the washout.
This is the portovenous phase, this one. Okay,
Okay,
this is the arterial. See here.
okay. There is some washout on the portovenous phase.
Okay, what about the portal vein? Tell me, is this patent or
It is causing compression over the right. It is causing.
okay? What's your final diagnosis, doctor? Hello, hello. Okay, doctor. To save
Atypical hepatocellular carcinoma.
why atypical? No, see.
Atypical hepatocellular carcinoma.
Atypical or
Yes, sir.
atypical? Atypical or atypical?
Sir, because some areas are non-enhancing atypical.
No.
Atypical.
See. Number one, it has arterial hyper enhancement, and this is one of the major criteria of HCC. Number two, if you accurately see here and here, you must find here. Look here, my colleague. This band here, it is complete, يعني almost wash out. Okay, so we have two
Yes, sir.
criteria: arterial hyper enhancement and washout. Doctor, you can compare
Okay.
the washout between arterial
Yes.
and delayed as long
Yes, sir.
as you are using extracellular contrast. You can compare not only with the portovenous. From my side, I like too much to compare arterial with the delayed. Why? It is very clear. There are hyper enhancement which washout.
Okay.
Okay, and another non-major
Okay,
criteria
sir.
is the mosaic appearance of enhancement or nodule within nodules. It was a case of classic HCC. By the way, the portal vein is compressed and not infiltrated. So if you look
Yes.
here, you will not see
Yes,
any
sir.
perfusional abnormality outside the lesion. Thank you, doctor, so much. Next candidate.
Thank
Take care, my
Assalamualaikum, sir.
عليكم السلام. Take care, my colleague. A lesion like this may be hyper vascular. See here. So you must, if you doing any biopsy, you must be ready with gel foam, and you must be ready with a good compression. After taking a biopsy, ask the patient to lie to the same site of biopsy to exert a compression. I think for about 30 minutes, something like this. Okay, my colleague. Thank you, doctor, so much. Our next candidate.
Yes, sir. Okay, it is. Uh, okay, sir. This is CT abdomen,
Yes.
plain and arterial phase, in which I can see that there is an area of hypodensity, heterogeneous hypodense area occupying most of the right lobe of the liver. And the margins of the liver are mildly irregular and nodular. However, I cannot see any area of capsular retraction. And in my routine practice, I would like to see it on post-contrast images also. And on arterial phase, I can see that there is a well-defined, rounded, relatively hyper to isodense area noted in the right lobe of the liver, noted at right at the confluence of right and left lobe, basically at segment
Four. Yeah. See,
4.
segment 4
Yes,
and 8. Okay.
4 and 8. Yes, sir. And it is also causing, and it was isodense on plane, iso to hyper on plane, and it is now on portal venous phase. It is also hyper dense, basically, and I cannot see any significant area of wash out on portal venous phase.
And
Um,
so one second. Now we
yes,
have mass in cirrhotic patient. The mass
yes, sir.
didn't have washout, correct?
Yeah, yes, sir.
Okay. The mass, is this mass has arterial hyper enhancement or not?
Um, some mild, not significantly enhancing.
Yes or no? This is the
Mm,
pre-contrast. Yes or
yes,
no?
sir. It is enhancing.
No. And
No, okay, sir.
we should ask the
No,
examiner, doctor, give me the pre-contrast. If you
okay,
see
sir.
some, see, by the way, my colleague, LI-RAD is very easy. Why?
Okay,
If
sir.
you see something like this in the
Mm.
pre-contrast hyper and the arterial hyper, sure,
It's benign.
he confidently said that this is non-enhanced.
Yes, non-enhancing. Yes,
So,
sir.
what's your final diagnosis?
So, sir, it can be an adenoma. It can be basically LI-RADS 1 or 2 lesion. It is benign lesion, but I will definitely go for. I will refer the patient if the patient is still in the department for MRI
Give me
to see
differential
its.
diagnosis in cirrhotic patient, hyper enhanced, hypertense
Sir,
lesion, non-contrast.
okay, sir.
Okay,
It can
adenoma,
be.
if she is a female, but this is not number one. What is number
Okay,
one?
sir. FNH can be one of the
No,
possibility, but in
no.
FNH there is a.
1 second. The patient is
Okay, sir.
cirrhotic.
So then it can be a sidrotic nodule, large sidrotic nodule.
Excellent. What is your next step?
Uh, MRI.
This is sidrotic nodule. يعني provisionally sidrotic nodule.
So then biopsy. I will.
Excellent.
Yes,
Biopsy.
sir.
Okay.
Yes, sir.
Biopsy.
Biopsy and AFP correlation.
Okay, thank you so much. My colleague, this is a sidrotic regenerative nodule. Sidrotic, what means by sidrotic? It contain iron deposition. That is why it is
Hemochrome.
hyperdense in non-contrast. Okay, my colleague, hyperdense in non-contrast. Okay,
Okay, sir.
very
Okay, sir.
nice cases of today. Different. See,
Yes, sir.
macroregenerative sidrotic hepatic nodule. Thank you, doctor, so much.
Yes, sir. Yes. Thank you, sir. Thank you so much.
Welcome. Next.
Please, any backup candidate can attempt.
Anyone ready? Hello?
Please, any backup candidate can attempt.
Dr. Ahmed, do you have anyone?
Yes.
I
I can take it.
Okay,
Can I take
I
it?
am here as a backup candidate.
Huh?
Shall we go to the backup candidate now?
1 second. I have very
Can
nice
I?
here. I think this one.
Can I take it?
1 second, my colleague.
Can I say?
Who Dr. Ahmed will share?
Sir, the backup
Doctor,
candidate will attempt. The backup candidate, candidate 8. Please attempt.
yes, I'm here.
Hello, doctor.
Yes, hello, Doctor.
I think we finished this one. This is the one we finished. 1 second. Okay, anyway. We have very nice case. I have. Okay, I have finished this one. This one, no. Did we finish this one? This is conflict. Okay, we can take any case. I prepare one fantastic case, but I don't know where is it. Is this one? Transient. Hey. Okay. Are you ready, doctor?
Yes.
Doctor, this patient, non-cirrhotic patient, what happened?
Non-cirrhotic patient. Okay, I'm presented with a CT.
Non-cirrhotic patient. Yeah, go on.
Yeah. Okay, I'm presented with a CT for a non-cirrhotic patient. This is axial cuts. This is arterial and venous. In the arterial phase, I can see that there is multiple heterogeneously enhancing lesions noted in the right hepatic lobe.
Mhm.
And these
Concentrate
lesions,
on this
these
one, please.
lesions.
Concentrate in
Yeah,
this
yeah.
one, please. Yeah. What happened for this one?
Okay. This lesions is heterogeneously with hypodense areas, likely necrotic areas, and the hyperdense enhancing lesions shows wash out in the venous phase. I would like to check
See,
also.
1 second. So you should see this is arterial phase hyper enhancement. This one,
Yes.
not
Yeah.
hyperdense. Hyperdense and non-contrast. You did
No,
well.
hyper enhancing.
This hyper enhancement part shows what?
Wash out in the portovenous phase.
Excellent. We are talking about
Malignant lesion.
which malignant?
In a cirrhotic patient, my first diagnosis will be HCC.
Okay.
Uh,
If I
I
tell you what is this?
but there is a capsular retraction there, and there is intrahepatic biliary radical dilatation. Intrahepatic cholangiocarcinoma would be
1
also in
second.
my differentials.
1 second.
Yeah.
What happened here? This area increased or decreased in enhancement during hepatobiliary.
This is increased enhancement.
This is with or against HCC.
Against HCC.
So you have two different pathways. Please have a look here in the what happened in the
This
delay.
is the delayed. In the delayed, there is increased enhancement in the lesion in the dome of the liver.
Where?
There's increase in.
Peripheral or central?
It's increased central enhancement with a central scar.
Okay. What's your diagnosis?
For this lesion, this is in keeping with the features of cholangiocarcinoma, increased enhancement in the delay.
1 second.
Uh,
Have two feature of cholangiocarcinoma. This is the feature, which showing increasing or delayed enhancement and the capsule retraction. Okay.
Yes.
One feature. What about the feature of hyper arterial enhancement and washout?
This is HCC.
So is this single pathology or combined mixed pathology?
This is combined mixed.
Give me a final diagnosis.
So this is a cirrhotic patient with complicated with HCC, which was HCC and intrahepatic cholangiocarcinoma.
This is one lesion, so mixed HCC-ICC. ICC means intrahepatic cholangiocarcinoma. So this lesion name is HCC-ICC, mixed. Doctor, do you know why this pathology happen in cirrhotic patient? In cirrhotic patient, we know that it is more liable to have HCC. Why he have
Mm,
a mixed HCC-ICC? Do you know?
mm, no, not really. No, I'm
It's
not sure.
it's a difficult question, but I will tell you. The progenitor
Mm,
cholangiocarcinoma is the same progenitor, I mean origin, origin يعني cell of origin to HCC. Both have the same origin. The origin called progenitor. Okay? Some HCC de-differentiated into mixed HCC-ICC. Okay, this is the cause. This is a type of de-differentiation of HCC to mixed type. So it is more malignant. Anyway, at least if you remark these two different contrast uptake manner, the examiner will be so happy that your eyes is well trained. Thank you so much, doctor. You pick up, but you forget to tell me, doctor. I wanted to check.
yes, I need to check the portal vein and the portal vein to rule out tumoral thrombosis.
Okay, and the ascites is hypodense.
And the ascites, yes, hybrid.
And what about this one? Biliary stent. Okay,
Mm.
okay,
Okay, yeah.
okay. Thank you, my colleagues. There are one question you can ask doctor. Dr. Jabir, you can ask.
Yes, I want to ask about is the management differ between cholangiocarcinoma alone versus cholangiohepatoma?
Management, I
Yeah,
think,
I mean
yeah,
the management is it different for the hepatobiliary team if I tell them if it's cholangiocarcinoma alone or cholangiohepatoma?
sure, because there are many different chemotherapy. So it has a specific type of chemotherapy.
Okay, okay.
Also, at least, do you know in the breast, for example, the pathology is very important because it has many different regimen for treatment. I think here also to give a diagnosis of combined ICC, HCC, sure, it will change everything because as I told you, mixed pathology is more aggressive than the pure HCC because this is de-differentiated. De-differentiated means more aggressive. Okay, doctor?
Okay, thank you, doctor.
Welcome. I will try my colleague to increase the number of sessions. Accept my apologize because I'm so busy, really. You can't imagine. So I will try to do another session and I will inform first of all Dr. Nahla if I can later on. Thank you, Dr. Ahmed. Thank you for all of you.
Thank you so much.